here in this room?
Yes.
The video and audio are working correctly? Awesome. I know a lot of you. My name is Dr. Josh Brandstatter. I'm a physician scientist here at the University of Pennsylvania, or there at the University of Pennsylvania. I've been recruited to David's mission, I would say, for the last 5 or 6 years now, since I finished my fellowship, and got really interested in how this disease happens and what causes Castleman disease. And then that kind of threw me into, so it started with a scientific question, and then I got to meet all of you guys, and I really love taking care of Castleman patients. Thankfully, at the University of Pennsylvania, we have some experience, and we have enough of you guys that I was able to build up just about as much experience as any provider has in Castleman disease practice. And I've made this sort of my main thrust. So it's both trying to figure out what causes Castleman disease in the lab and taking care of patients with Castleman disease. And then this new role that I've inherited from Sheila Pearson over the last year, which is also directing a lot of our clinical research efforts, where we take advantage of all that medical data you provide to our registry and try to use that to answer questions that we all have about the disease, you and us as doctors, and to find if there are any other patterns or things we can, suss out about the data, so we can tell stories and tell your collective stories to the larger medical community. So it's not just, oh, you happen to come through the doors of the University of Pennsylvania and you then get the the benefit or wisdom that any doctor at any place can ideally look up this information and have it at their fingertips. And I'm going to tell you one of those stories today about unicentric Castleman disease that this gentleman sitting calmly right here helped us to tell about unicentric Castleman disease patients who have multicentric-like symptoms. And I suspect that might be a lot of the patients here who have had that sort of situation, even though most doctors who have treated any unicentric Castleman might tell you that that's not a thing. Okay, so let's see if I can advance a slide. All right, we're going to talk about the overview of unicentric Castleman disease. We're going to talk about its treatment, its presentation, and I will give you a little bit of a sneak peek into some of the things that I'm thinking about causes of Castleman disease in the lab, with my efforts being mostly focused on unicentric disease, because I think there's some better suggestions of genetic changes that give us a little bit of a useful sort of cudgel into learning more things about how Castleman is caused. And so if you've seen me in clinic, I say that even in 2024, we have a very simplistic understanding of Castleman disease. It is a big lymph node that looks a certain way under the microscope. That's the only thing that you can really say that's unifying for everyone with all different kinds of Castleman disease, is a big lymph node that looks a certain way under the microscope. It looks a funny way in some, there's some very specific changes that in the science station they can talk to you about. But that's really the most unifying thing. Big lymph nodes looks a certain way under the microscope. And then, I threw up number 3. It's also not anything else that we can find that's usually more common. It's not an infection. It's not an autoimmune disease. It's not a cancer, because sometimes you can have even Castleman lymph nodes with these other conditions, where it's the other condition that's really just causing a big lymph node that just happens to look a little bit like Castleman disease. Most unicentric Castleman disease patients are asymptomatic, and I presume that means nothing to anyone in this room, but it's still the truth. The far and away more common, I see this both in my own practice and from the literature, is there's someone who got into a car accident, or maybe they were a guy who's shaving or something like that, and lo and behold, there was a lymph node. The CAT scan that was just supposed to find a broken bone after a car accident found big lymph nodes somewhere there wasn't supposed to be. That lump that just seemed like it was slightly growing but wasn't really bothering them, and eventually a doctor did an ultrasound that led to a lymph node being found that got taken out. That's the most common way a unicentric Castleman patient presents. Big lymph nodes in one area, asymptomatic, found accidentally. This concept of single region also probably deserves a little bit of attention because it could certainly be unicentric means one lymph node region, but it can be multiple lymph nodes in the same lymph node station, as they're called, these sort of different areas. So even if it's more than one lymph node, if it's in the same spot, we call it unicentric disease. It's rare, but I think what this group has been helping us to learn is that not quite as rare as we've all assumed. Still affects a number of people, and most patients do extremely well with it. So the average unicentric Castleman patient is found a big lymph node, got it taken out, and that was the end of their Castleman journey for the most part. I suspect I don't even see a lot of them because they don't even get referred from the surgeons.
Doctor, are they still considered as having UCD?
Yeah, they would still be UCD. And that would be the most common UCD patient, probably, are patients who I might not even ever see. And that's why I'm saying the only thing that's unifying here is a big lymph node looks a certain way under the microscope. It's a lot of other differences between all the patients that we call Castleman. So it's rare, poorly understood, but we are learning. This was a big step forward just a couple of years ago where we have these consensus-based diagnostic and treatment guidelines for unicentric Castleman disease. If you have a doctor who close to home and they're like, I don't know what to do for unicentric Castleman disease patient, there's the paper they should read. That's the Bible right now for how a doctor should manage Castleman disease, that draws on the collective wisdom of everyone on that list to all saying, these are all the things that we do and what we agree should be done for unicentric Castleman disease patients. This is the way that we're trying to, as I say, standardize care. So it's not just a matter of you happen to, travel how many different hours to some big institution where it has horrible parking and long traffic and blah, 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 other inconveniences of bureaucracy. This is what we're supposed to, this is our attempt to try to make sure that all care can be universalized and you can get the same care no matter where you are. And it will help a doctor close to home have the tools to understand what to do to take care of a unicentric Castleman disease patient. The major symptoms that they cause, to the extent that they cause symptoms, are compression on adjacent structures. They're getting big and I'm starting to feel pain from that area. It's getting big and yeah, I'm having some trouble swallowing in my neck because it's these big lymph nodes and neck are pushing on my esophagus or making it harder for me to breathe, or I'm getting some swelling in my leg, or there are patients who, despite having unicentric Castleman disease, have an inflammatory syndrome very similar to patients with multicentric disease. Now, it's not similar to the multicentric Castleman CAFRO variant, where they're in the ICU about to die, like David's story with the disease, but it's still quite disruptive to any semblance of a quality of life, their ability to go on and go to work, take care of the kids, and do all the things that they need to do to live their life happily and successfully. So those symptoms certainly come into a certain percentage of unicentric Castleman disease patients. And there are a couple of different rare phenomena, complications of unicentric Castleman disease, which leads into why the treatment regimens are what they are, which is one, that these sort of secondary autoimmune phenomenon can occur where Castleman disease, as I know David talks about all the time, is sort of at this nexus of autoimmune, cancer, and infection, in the sense that there are patients with HHV8 who have this virus that caused their multicentric Castleman disease, but we can't really find any virus, and for most of the cases, we don't have that. Some patient, there's a lot of similarities to malignancy. Certainly, a lot of people think that they have a cancer when they first get a scan with CAS showing a big lymph node. And there's some more evidence to think about these sort of idea of cells copying themselves to make a growth that could be happening in some patients with unicentric Castleman disease. And there's the whole idea of autoimmune. Certainly, it's the immune system behaving badly, but what makes it a little bit different from autoimmune is that it's not attacking any one organ system, right? If you have ulcerative colitis or Crohn's disease, the immune system's attacking your gut. Multiple sclerosis is attacking your central nervous system. Not necessarily true for Castleman's. It's not attacking any one thing. It's just revving up and going crazy when it shouldn't be. So it sits at that sort of nexus of these things. But unicentric Castleman can cause a frank autoimmune condition where now the white blood cells are attacking the mucous membranes around your mouth and esophagus, causing this disease called paraneoplastic pemphigus, where you can't swallow because you have so much pain from these bad lesions in your mouth and esophagus, or that are attacking your lungs, making it hard to breathe. These are rare complications. I would say almost all of the ones that I've seen in the literature and that I have personally been involved or heard about their care have been in kids, but that is not universally true. There have been a few cases that I'm aware of that happening and that were also mentioned in the literature that have happened in adults. They almost always happen at presentation. So it's usually this lymph node was growing asymptomatically for someone for a while, and then they first notice their first manifestation of the disease. The first way that they know that they're sick is because they were developing this paraneoplastic pemphigus and bronchiolitis obliterans. And this happens to, I would say, overall, a low single-digit percentage of patients with unicentric Castleman disease. The other condition would be malignant transformation. Again, this is a rare complication. I am aware of several cases. Just had one recently at the University of Pennsylvania where patients had unicentric Castleman disease. Again, this oftentimes happens for patients at presentation because the unicentric Castleman was growing asymptomatically and they never knew it was there. And then they get a transformation into lymphoma or this other disease called a follicular dendritic cell sarcoma, which is another kind of cancer that can arise from some of these, from the cells in the lymph node. The way we usually know that they're associated is because you can see on the pathology when the lymph node comes out, they see some areas that looks just like Castleman disease, and then they see some areas that show the cancer. Again, this is a low single-digit percentage, but it is there for patients with unicentric Castleman disease, and it's something we should always be mindful of when we think about what do we do when we find these big lymph nodes, and that is total resection of the involved lymph nodes as the first-line recommended therapy. And this is why I think for patients in this room who are more likely to have symptoms from their Castleman disease, this seems like a no-brainer. For patients who are completely asymptomatic, though, telling them they should go get a surgery when they're feeling completely fine does cause them to ask the obvious question is, why? And the answer is because of these low long-term risks. So I counsel patients that this isn't something you need to go and have done yesterday, but it is something we would recommend you get sooner rather than later and not let just, several years go by. But of course, for asymptomatic patients, there's always a risk benefit and they'll always make their own decisions. I had one patient who he found his Castleman disease very accidentally he works in a warehouse, so he's always been much better shape than I am. And he had back pain because he works in a warehouse. And they did a scan to find the source of his back pain, and they accidentally found big lymph nodes in his back. And that's a hard place to get surgically. So after he had one out for a biopsy, he said, thanks, but no thanks. I don't want another huge surgery. And that's completely reasonable, I think. And so we're just going to follow him until he may change his mind about that long-term risks. He's a young guy right now. So every patient will make up their own mind about the individual risks and benefits of doing surgery, but we do recommend first line of therapy for unicentric Castleman to be complete resection of all enlarged lymph nodes because of either the fact that the patients are symptomatic at presentation or because of the small long-term risks of malignant transformation and secondary autoimmune phenomena. What do we mean by total resection? This is an issue that comes up, I would say, not uncommonly. Maybe it's more the surgeons who ask me these sort of questions. Typically doesn't have to be the sort of like more extensive, like, total axillary, complete axillary dissections that patients who may have like breast cancer may get, where they're removing all of the lymph nodes in the area that make them very high risk for lymphedema in the arm. This is really just, if the lymph node is enlarged, you take that one out. And then we go into surveillance. Again, thinking about the overall excellent prognosis for patients with unicentric Castleman disease, you want to weigh that morbidity, right, against the problems of a too aggressive surgery. And so the main thing is we recommend is that all enlarged lymph nodes get taken out for the surgery, and that's it. Other lymph nodes can be left alone in that area. And otherwise, we'll follow the patients to see whether, with imaging and clinical evaluations, to see whether there's any indication to do a more aggressive surgery than that. And that's been, yeah, of course.
PET scan get done before surgery, right?
You're completely right. There's a whole slide here that I think is probably missing, which is what's the diagnostic workup.
Yeah.
So you find Castleman, what do you do about that, right? It's a really good point. So they'd say they find a big lymph node, right? That's how this all begins, how you suspect Castleman disease. It shouldn't, I tell my patients, it's like, there are going to be a lot of great doctors there, or, just remarkable clinicians, human beings, know everything in the world, who have never taken care of a Castleman patient before. And for the most part, they'll get through their careers, right? And be okay. So Castleman is not going to be first, second, third, and what a doctor's going to be thinking when someone comes with a problem. But when they get a lymph node, that changes things. And when they take that lymph node out to look at it under the microscope, then they have this idea, this diagnosis of Castleman. And then what do they do with that, right? Well, one is the kind of biopsy they do, right? So I can probably, here, how many people started their biopsy journeys with a needle biopsy, a fine needle aspiration or a core needle aspiration? Yeah, okay. Anyone else? Or everyone else went straight to excision? Okay, awesome. There we go. But a lot of patients do get these needle biopsies and they get no answers from them. Because exactly. They're great because what they can do is, if you were suspicious of things that are more common, like maybe a solid malignancy, a part of your non-white blood cells that are cancerous moving to a lymph node, because that's where solid cancers like to live. Well, then you can pull those cancer cells out and make a diagnosis. But for something like Castleman, where you're dependent on this sort of pattern of lymph node changes, you really can't get an answer that way. Can't get the diagnosis through core or needle or fine needle aspirations, with a few exceptions to that. So you typically need an excisional biopsy that takes the whole lymph node out in a surgery to look at that under the microscope. And that helps you get the diagnosis. And then now you have the diagnosis of Castleman disease. And hopefully you do, because certainly you can probably all know that sometimes pathologists disagree, and there are different pathologists with different experiences diagnosing Castleman disease. What do we do? And that, what I would say, is a PET scan. Because a PET scan will tell you two things. One, it does the job of staging you, right? Are you unicentric? Are you multicentric? It's going to look head to toe everywhere. You have lymph nodes. What are the sizes of those lymph nodes? And not just what the size of the lymph nodes are, because this is the added bonus that you get with a PET scan over a conventional CT, but how hot, how bright are those lymph nodes? Meaning, how much are they taking up that radioactive sugar dye that gives you a sense of how angry these cells are, how much rapidly they're dividing. So you get not just this lymph node is 2 centimeters when it should be 1 centimeter, you get how bright it is. It has this uptake of the dye at this level as opposed to this level, suggesting it's really bright. And so that not only helps you to see where all the disease is, but also gives you a sense of whether you might be missing something, whether you're only seeing part of the picture with the lymph node that you took out. Oftentimes, in the rare cases where patients come to me before when they were just thinking about Castleman, but maybe they haven't had an excision taken out, or maybe they've had one, they still don't have an answer, and they come to me, I like to get a PET, because the PET can help me choose which lymph node to biopsy. The one that's the brightest, that's going to be where the disease is really living. So if patients who have had, and maybe people in this room have had this situation where they took a lymph node, they did this whole surgery to take a lymph node out of me, and they still don't have a diagnosis for me. The best next step is to make sure you have a PET scan and target the lymph node that is the brightest. That will help you if in case you don't even have a Castleman diagnosis, you've got no diagnosis, can help you to reveal whether it is Castleman disease, but also could point if there was something else going on, right? If you had a lymphoma, well, if there was a super, super bright lymph node there, well, I'm going to say, even if you have that Castleman diagnosis, let's go get that lymph node, because I want to make sure we're getting something, we're not missing a lymphoma, right? Traditionally, that's not the case, but that's just part of being, I think, a thorough staging exam. Also part of the staging for all new diagnosis of Castleman disease, whether you're unicentric or multicentric, would be blood work, looking for biomarkers of inflammation, blood counts, serum chemistries, liver function tests. The albumin, as you know, can get low as part of how the body feels inflammation from Castleman disease. Blood counts can go awry. All these markers we have of inflammation can go up. None of them are specific for Castleman, as I'm sure everyone here knows. There's no one blood marker that just goes up for Castleman disease and nothing else. They're just general measures of inflammation. I like to check a bunch of them. For patients, I would say that would be the missing slide of how you work up Castleman disease. First line is resection. That resection should be of all enlarged lymph nodes. There are certainly patients who cannot get resected, in which case, and that's because of where their disease is. It's just not in a good spot. There's surgeons, and I oftentimes we even make sure, like, even if one person's surgeon says that they're not resectable, it's like, go see another surgeon just to really make sure we feel comfortable that the disease is not resectable, or that it would be not unsafe to resect it. But in those cases when it's not resectable, you may need to do something about it because of where the lymph node is located, right? Maybe it's in a really bad spot. It's stuck between the big vessels coming out of the heart. And if it grows there, it can really start to cause you severe problems. And so what do you do for patients who have unresectable disease? Well, one is you can consider just a partial resection. Unicentric Castleman disease grows slowly. It grows, but it grows slowly. Patients who get diagnosed with unicentric Castleman have probably had the disease growing in their bodies for maybe years, months at least, but maybe years before we actually caught it and everything like that. And so it grows slowly. And so sometimes if you're at a point when you're in a tough spot, you can't cut it all out, but it does look like it might cause problems. Maybe you can cut part of it out. And that might be worth it to some patients to do a partial resection of the disease, knowing that that buys you several years before you're going to need to do more things to try to shrink this disease. Most get complete cures with resection, but this is, of course, not the end of a lot of patients' stories. And I suspect it's not been the end of anyone's story here in this room, whereby they can get their surgery and they still have problems. There's still symptoms and they weren't made better, even though I did the thing that you just told me was the consensus guideline treatment recommendation was the complete resection. I still have a problem. I'm still feeling those inflammatory effects. They got worse for me actually after my surgery or something like that, right? These stories we've heard, these stories we've shared. And this is one of the wonderful things that the registry has allowed us to do is it's not just a matter of you telling your doctor now, hey, doctor, this happened to me. And then your doctor saying, well, they said to cut it out. I cut it out. You should be better. You probably just making up your symptoms because it said, so the paper said you should be better now. I know very little about unicentric Castleman disease. What I do know is you're supposed to cut it out. And we did that. Your story is over. You know, goodbye, right? And this was a wonderful thing that we were able to use in the leverage the registry, which was to share everyone's stories of having unicentric Castleman disease, having a complete resection, and not being better, still having symptoms. And this is now a way that we can tell doctors in an organized way that they will listen. This is a thing. Here it is, American Journal of Hematology, saying that patients we've seen through our registry can have complete resections and still have symptoms. Here are some of the symptoms that we've been able to say. And telling this story collectively as part of everyone's experiences as a whole is so much more powerful and allows us to say in a much more convincing way that this isn't just one person's experience. This is things a lot of people are dealing with together. And something you should acknowledge and think about may need special treatment and may need its own a fresher reevaluation besides just saying that's not a thing. And this is one of the wonderful things about as I said, about the registry, and why when I was asked to take on the registry responsibilities last year, this paper was in the pipeline already. I teased this last year's summit and loved one patient summit, patient and loved one summit last year because I thought it was exciting, and now it's been formally published. And it's one of the things that really got me excited about doing this work, because I think it's wonderful that allows us to take priorities that come from patients and that we see from clinical care, and now have a formal way of generating insights and sharing that with the larger medical community in a way of telling them what, redefining what this disease is and giving people a better picture. This is new terrain. Is one of the exciting things about being in rare disease research is that we get to tell these stories. Frustrating, of course, for patients because these stories aren't already told. They should already know these things, but they don't. And so we get to be the ones that tell it. And with the registry, we are allowed to do that. We can ask it questions, say, are these common experiences, and find stories that we can tell clearly, and hopefully then change practice and let people, let providers everywhere in the world learn and have the information they need at their fingertips.
Question from the Zoom.
Please.
Amina asked, you said UCD grows slowly in patients. She says in her daughter, they resected a 5 centimeter mass, and 1 month later, in the same place, they found a 4 centimeter mass. You have any?
Oh my gosh,
about that?
that is extraordinary. I don't think I said this at the beginning, but I will always say one of the things about rare disease research is you always have to stay humble, because it's a rare disease. And because I would say there's also heterogeneity in the disease. There are a lot of differences. As I said, the most unifying thing is you have a big lymph node that looks a certain way under the microscope. You always have to be, and then there's all these different ways that patients present. You always have to make sure you're humble, that you can find idiosyncrasies and differences. On the whole, unicentric calcium disease does grow slowly. When I see evidence of growth more quickly, it does give me pause, and I want to really make sure that there's not something else going on there. So the adequacy of it was a partial resection, is what the person was saying.
Lisa, they had a total resection.
A total resection.
6 and
okay.
a month later, 4.
I would make sure that they've had a PET and make sure there's no evidence of something else going on. And that would be my main recommendation, would be to make sure that there isn't a more active, frankly, malignant process.
And they said in the media style.
Yeah. So that would be my recommendation, is to make sure that whether it's the review of the mass that was already taken out, even getting a second opinion, make sure there's no evidence of malignancy in that, and make sure they have a PET to make sure there's no other areas that can be sampled to show that there's something like super bright on a PET scan that suggests a more proliferative process, that something cells are just going like crazy, because that would be fast. I would not expect that. That said, always be humble with the disease, and you can say things. You can be the person standing up there saying, this is what we see in the disease, but you always have to be humble about there being differences. So that would be how I would respond to that. Symptoms can vary. These are the common ones. They're inflammatory symptoms. These are the symptoms of a really bad flu that never went away. There are differences. So some people in this room might be saying, wait a minute, my symptom's not listed up there. Or I think about my Castleman completely differently from the way he has it up here. And that can certainly be the case. this would be the most common. For patients who are saying that this is not fits with their experience, I would say one, it always is important to make sure that that thorough workup has been done to exclude other reasons for having enlarged lymph nodes that look like even large lymph nodes that 100% look like Castleman under the microscope. I'll say one patient who I saw, and she told me my Castleman disease is different. My Castleman disease caused me this really bad complication called burning mouth syndrome, because I had such severe dry mouth and my whole mouth was on fire. And I started talking to her, and she was saying, "Yeah, my eyes are also really dry." And check some blood work. She actually has Sjogren's syndrome, this autoimmune condition. She definitely had big lymph nodes. They definitely looked like Castleman under a microscope. Her local institution thought so. University of Pennsylvania thought so, but she actually had Sjogren's syndrome. And so sometimes when your symptoms are very different, I do think a thorough work. I'm not saying there isn't differences in the disease, and I'm not saying we're not always going to be able, but we always want to make sure we've thought thoroughly about alternative explanations for your symptoms and whether there could be other things going on, even if you do have big lymph nodes that look like Castleman. So you always want to be careful about that. But these are the main symptoms I would say the patients experience. I've stolen this last line from Dr. Sunita Nasta here, which is anything that satisfies the 3 Ps should be a symptom that you would report to your physician. It's puzzling. What the heck's going on with this thing? It's persistent. It ain't going away, even when I put an ice pack on it or lifted my legs or whatever, took a Tylenol, and it's profound. This is really bothering me. Those are the reasons to touch base with your doctor about symptoms you're experiencing, anything that satisfies the 3 Ps. And I think I always like when my patients report symptoms, I can sometimes have an unsatisfying answer saying, I don't know how well I can relate that to your Castleman disease. But I always like that at least I know, and gives me a chance to think about that. Please.
Just for the skin lesions.
Yeah.
Meaning more like infected cysts, boils, that kind of stuff.
The common, so they're the cherry angiomas that are
Okay,
common in
yeah.
multicentric Castleman disease. Are, I would say, the more typical inflammatory lesions. There are a lot of different kinds of skin lesions that can happen though with Castleman disease, because as I said, it's actually I didn't say this. It's these big lymph nodes that look a certain way in the microscope. In the case of multicentric disease or the patients with unicentric who are feeling these inflammatory syndromes, it's the body going to war. It's on fire a little bit. And that can cause a lot of different kinds of skin inflammation. So I've certainly seen things that are not that classic cherry angioma that is in David's book and everything like that. And I do think about them as being disease related, but not necessarily. So that's usually what. All right. So for unresectable lymph nodes, as I said, you can do a partial resection. Other strategies is you can zap it with radiation. That's can be wonderful, with the exception of maybe it's also not a good spot to zap. And you always want to make sure you have a good diagnosis, because once you zap something, you can't know what you zapped. There's another strategy called embolization, where it's a procedure done by interventional radiology, where they actually can cut off the blood supply to the lymph node. Castleman lymph nodes are very vascular, they're very bloody, and they like to have themselves well supplied, and cutting that off can cause the lymph node to shrink. Simple things like steroids can shrink lymph nodes. Well, steroids are the magic drugs that aren't. I always look at patients' loved ones before I prescribe them.
Then I got steroid-induced diabetes.
Yeah, well, that's it. They're the magic drugs that aren't, right? They can be great because they can treat so many different symptoms, but they cause so many other problems with them. And it's always a matter of thinking about steroids in the context of short-term Band-Aid therapy. I'm feeling really bad, doc. I need something right now because I can't take this. Let's cool you off with some steroids to help control that. But we're not going to do them too long. We're going to think about a clear end date for them and think about what we get you on that works so we can get you off steroids and keep your disease under control. Steroids can certainly shrink lymph nodes. Rituxan can also treat lymph
can also provide a treatment strategy for unresectable Castleman lymph nodes, because it basically is a monoclonal antibody that targets this molecule CD20 that's on the surface of B cells. And if you took a lymph node, smashed it up, and counted up all the cells types in there, most of them are B cells. About 85% of the cellularity of a lymph node are B cells. So by killing B cells, you can shrink a lymph node, and that can be efficacious in getting patients who are not surgical candidates to become surgical candidates, so they can get that complete resection, just like the patient who had their lymph node in a very easily accessible spot. So that's another strategy of making people who are unresectable resectable. Side effects. Almost all of them have a side effect of immune suppression. We have an immune system that's on fire, that's not behaving well. All of these are different ways of bopping the immune system on the head. They have different degrees of immune response, of immune suppression. Steroids probably being the biggest bop to the head of the immune system. Some of them can also come with more idiosyncratic side effects that are related to those specific therapies. This is one of the slides that I was just told was added into my talk, and it was to bring out this concept of oligocentric pathways. Paper coming out, the paper is submitted, is being reviewed right now, that will tackle this subject more directly. So right now, this is mentioned in the unicentric Castleman disease diagnostic criteria, but you got to look for it. And so if a doctor is just trying to think about this right now, they got their unicentric paper, they got their multicentric paper, and hey, 2 is more than 1, right? That must be multicentric then. And I can't tell you how many doctors say this to me all of the time. 2 is more than 1, so therefore it's multicentric. It can't be unicentric. But geez, if it doesn't kind of look like unicentric, it might be here and here. So there are 2 spaces that are right next to each other. And they certainly aren't like the Tafro patients going into the ICU or something like that. A number of oligocentric patients might be even diagnosed on accident, like a unicentric patient might be. It's just that it happens to be in more than one lymph node region. And they don't meet all the diagnostic criteria about this body on fire from inflammation in terms of their symptoms and lab results. But they definitely have Castleman. It's definitely more than one spot. And so this is a paper that's supposed to define this and have this as the focus, this oligocentric, this thing in between unicentric, one spot, multicentric, many spots. And I think we consider oligocentric often in the treatment algorithm of unicentric disease, because I would say the patients often are phenotypically similar. They look and present very much more similarly in the sense that they can have some inflammatory symptoms and lab abnormalities, but maybe don't quite meet the IMCD criteria. And cutting their lymph nodes out seemed to provide similar benefit for a lot of them. And so I think about them as being like unicentric Castleman disease. But they have their disease more in one spot. So this is a new thing that we're just starting to more systematically describe. And I think having this paper out is going to be a huge benefit for helping patients everywhere get their disease entity recognized by their local providers. So you don't have to be at a place like Penn or Memorial Sloan Kettering or blah, 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 where there's someone who's actually been treating Castleman patients regularly. Okay.
I have a question.
Please.
When you look at the universe of research across UCD now, oligo and then multicentric, do you find that the research that's being done, say on multicentric, is the findings are, very applicable across the universe, or kind of looking like, you know what, like there's a lot of stuff here that really we just need to look at UCD because the findings are not as relevant to, you know, the UCD world.
Yeah. Trying to think if there is a good across the board answer to that question. Right now, in terms of a lot of the clinical data, I would say that they are not necessarily applicable, with the exception that of the UCD patients who have systemic symptoms. We're certainly just cribbing from the multicentric playbook and applying those therapies to unicentric patients. The idea of the bulking, though, is not really a strategy that means anything to multicentric disease. Their lymph nodes actually for multicentric aren't that large, which is one of the differences between unicentric and multicentric. A unicentric patient could get a lymph node that's quite huge. Multicentric, they're just a little bit bigger than normal, really. It's just the inflammatory phenotype is so severe that it's causing the symptoms. And so the idea of this sort of like debulking strategy, which also can affect how we choose drugs for when we do use systemic therapies for unicentric patients, doesn't really play with the multicentric at all. So there are some limitations to that in terms of size is an issue in unicentric, not an issue at all in multicentric. But to the instances where unicentric has issues with inflammatory syndromes, then we certainly look at the same multicentric drugs. Like if you look at even all the multicentric drugs that there are, all of them are different kinds of immune suppressants. And so the fact that a unicentric patient is having an issue with an uncontrolled immune system, it makes sense that a lot of those drugs are going to have activity and are going to work for unicentric patients with systemic symptoms who are having an inflammatory disease. Just like they work for a lot of other different inflammatory diseases that have completely different ways that they work. A lot of this is our limited understanding of what's really going on here that causes us. We have all these tools that do different things to suppress the immune system. And guess what? They're going to work against a lot of different inflammatory diseases. And so that's a long way of saying there's some applicability, but there are limitations to that. I think this slide that I made became redundant based on the other slides that we were put in.
Question about.
Yes, please. Yeah.
So a patient said they were diagnosed from, an adrenal tumor. 4 weeks later, they did the PET and they showed 2 sites of activity in the left lower quadrant. Her doctor says isn't repeating the PET, but she has pain symptoms. She's asking, does this sound more like a oligocentric, and if she should push harder for?
She had disease in one area.
She had
Okay.
a complete resection,
Uh-huh.
and then when they imaged, they saw it was in 2 quadrant, well, 2 areas of the left lower quadrant.
I see. Well, that could be that could be a oligocentric disease for sure. Without knowing any of the, all the caveats of being able to answer a very specific medical question for someone through this platform, it does make me suspicious of that. Okay, so what can I do after receiving a diagnosis? I think everyone here knows these sort of things. Can find a Castleman disease experienced clinician, although we're hoping we get to a point where that's going to be less and less necessary. I like always helping doctors or patients directly, but ideally they shouldn't need to, right? We want to get to a world where this can just be treated by a normal hematologist anywhere in the world using the playbook that's been published and that's accessible to them. Monitoring laboratory values. These are the inflammation markers I was talking about. They can include the sedimentation rate, the C-reactive protein, VEGF level, IL-6 levels, although there's some questions about like exactly how well those can correlate with disease. I still often check them for patients. Sometimes you might find the level that's the best for you in terms of your disease. Because I said there's a lot of differences between all of the patients in terms of what we all call Castleman disease.
So are you suggesting we learn how to track this or you guys? track
Oh,
it? Because
Yeah, doctor,
we're getting overwhelmed.
your doctor should be checking it.
Yeah,
And I suggest the frequency of which sort of depends on the severity of your symptoms, how up and down things are for you in general. They could be checked quite infrequently if you're totally fine, of course. But if you're not, then that could cause you to be checked a little more frequently. And yeah, I would say in terms of I don't think the patient should have any responsibility in tracking those things. But practically, of course, sometimes it's good to make sure you have some, that you take some ownership of these things, especially if you have any concerns that your doctor might not be. So I would say you shouldn't have to, but I also want to empower you to, if you feel like it's necessary to be able to track. Sometimes always making sure that we think about multiple different lab values. It's very easy to see, oh man, it put an exclamation point next to that lab value on the electronic medical record. Thinking about how far they are from the upper limit. Sometimes doctors can help with the interpretation of these. How far away from the upper limit of normal is it really? And thinking about sometimes lab values over time. A lab value is always just a snapshot. It's like now we're in the election season. Polls are just a snapshot. Lab values are just a snapshot in one particular time. Trending them is sometimes important. It's one thing if you had one value that was a little bit up because maybe you had some sort of subclinical infection going on that day that you didn't really feel. And then, oh my gosh, then it's totally normal 3 weeks from now or something like that. So the trends matter is what I'm saying. Always thinking about mind body is important. I would emphasize this in the context of patients with unicentric disease who feel systemic symptoms, like inflammatory symptoms. I think one of the most common things is their providers tell them it's in your head, you don't really feel those things or something like that. And what it is always true, of course, that your mind and body are connected. It is always true, of course, that doing important things like sleep, like good sleep hygiene, exercising regularly can help with the dealing with just if you could have pain from a broken arm and you could still feel better if you do these sort of things. It doesn't mean that you don't have a broken arm. It doesn't need to be fixed. And so it's always important for your general health and wellness to think about these things. And that's why I thought it does deserve mention, at least here, even though it's not like it doesn't mean your doctor shouldn't be doing something necessarily for your symptoms. Helps rule these things out, what I would say for doctors who might be on the fence or something like that about what to do. Is like, look, I'm taking care of myself, so it's up to you, doctor, to do your job.
Question,
yeah.
So I think Lisa shared a very powerful story about exactly demonstrating how it's hard to get some of these lymph nodes out.
Yeah.
Her daughter had one surgery, tried to get them out, couldn't ID it. Lost almost all the blood in her body when they tried to get one out around her femoral arteries. And now she's asking about recurrent UCD because in the same region, new lymph nodes came back 5 years later, and they're wondering if what the treatment guidelines recommend for recurrent UCD.
Yeah, that's a great question because I didn't even mention that. So I'm glad that they brought that up. So recurrence is rare. So it is, to the extent that we've seen it, it's been, again, like a single-digit percentage that it recurs. Usually when patients get their lymph node out, it's just done. In fact, what we've even observed is there's some patients who have like a dominant lymph node mass, and then they have like what almost look like satellite lymph nodes like around them. They just get the dominant one taken out, and then they just they deliberately, because they don't want to get another surgery after that, they kind of wait on the other lymph nodes, and they just regress on their own. And they don't need that second surgery then. So I would say recurrence is rare. Sometimes the other lymph nodes can even regress when a dominant mass is taken out. But to answer that question, is it still happens. Even if it's rare, it still happens. And the recommendation would be a complete resection of the recurrent lymph nodes in that case. And the reason would that be is what we suspect is to the extent that it does happen, it's likely because maybe there was a lymph node that was borderline, got missed in the surgery or for whatever reason. That's why we still recommend some degree of surveillance We still do imaging. Think about for younger patients, you always don't want to overdo CAT scans. And you don't want to make someone glow. So you want to temper your imaging. You don't have to do it every 3 months or something like that. But we do want to have some sort of surveillance strategy that does involve a kind of imaging modality as part of that more comprehensive assessment for surveillance to ensure that there isn't a regrowth at the site. And in the case of when there is, usually because something maybe gotten missed in the surgery, which can happen, it's not necessarily the fault of the surgeon that something got missed. Could have looked fine at the time, but that was a disease that was growing. And then in case it would be a complete resection, would be the recommended treatment.
Maybe if her surgeon said they can't take any out again, let's try radiation.
Then we would go through this path of treatment for unresectable disease, as I was talking about before. The one thing I will add on, and I'll actually bridge me into research updates, is if even if in a world where like maybe they've tried a lot of these things that I had on board, right? And they're still like, yeah, doc, I just did everything you said and I'm still having trouble. Well, there are other, for example, there are other next generation CD20 shrink directed antibodies, like obinutuzumab, that can work a little bit better than Rituxan in killing B cells and helping to shrink lymph nodes that may get them to a point of surgical resection. And again, transitioning here to what I was saying about research updates, there was a survey of about 40 different unicentric lymph nodes, and they found about 17%, I think was the number, had this particular PDGFR beta mutation, had a particular gene mutation in it. And the gene was called PDGFR. I'll have a slide with it written down. And if you happen, I am completely unaware of any patient actually being treated for that direct mutation before, but it's there. And there are drugs that treat that mutation, that mutation in other disease contexts. And you could think about that as being a new way of trying to shrink a lymph node that needs to get shrunken to get it surgically resectable. And I'll talk about that in a little bit. So let me talk a little about what we're doing in the lab, always what I'm doing. I'm really interested in parts of the lymph node that are not the white blood cells. They're not the main effectors, not even most of what's in a lymph node. I'm talking about what's maybe about 5% of the cell or less of the cellularity of the lymph node are these structural cells of the lymph node. And I am very suspicious that they may play a role in causing the disease because they're not just structural cells. They're not just cells that make up the walls of the rooms of the lymph node. They play an immunologic role. They they talk to the white blood cells, and they can help get them ramped up. They look funny. It's part of this definition of the disease that they look funny under the microscope in Castleman disease. Part of how you define the disease is you see changes in follicular dendritic cells, which are these kinds of structural cells that play an immunologic role in the disease. And in some patients with unicentric disease, like the patients who I mentioned who have this gene mutation, and other patients, and they actually have evidence that they're of clonality. That these these lymph node cells that are not white blood cells, I call them stromal cells, that have this sort of air traffic control role. That's why they play in controlling the white blood cells. There's some evidence that they're actually copies of each other. They have a gene change in them. This has been my interest in unicentric disease in particular, because we don't see this in multicentric disease at all. But there's this concept of clonality, of cells that are all copies of themselves. Just like you might have a colon polyp, right? It grows and grows and grows in your colon until they found a colonoscopy and they take it out. These cells are sort of growing in a similar way, but they are different from the cells that line your intestine. They are immunologically active. They signal, they talk. And I suspect that they could be causing a local inflammatory response in the context of unicentric Castleman disease that might be felt even more widely. And so that's my little in here. I've been doing a lot of work for patients who have donated lymph nodes. This is some of the things that we do a lot of different studies with lymph nodes, but as part of what we've been doing is trying to find these 5% from the big mass of all the white blood cells, define all those different kinds of stromal cells, of these cells that are structural of the lymph node are. See whether there are specific kinds that seem like they're increased in, let's see, do I have control? Yeah, that seem like they're increased. Particular kinds of these structurals that are increased in unicentric disease compared to patients who have big lymph nodes, but who don't have Castleman disease, who have reactive lymphadenopathy. Then you can take all these patients who have something in between, and you can find a subset of them that look a lot like the unicentric Castleman disease. So maybe this will help us to make better diagnoses of Castleman disease. As I said, there are patients who have this as the gene, PDGFR beta. Oh, sorry, it's about 17% have these mutations in this one study that was done. And this is treatable. There are FDA-approved medications that can work against this particular gene. I've tried them in a culture, and you can see some of them really do a good job of controlling cell growth from this mutation. They're actually used in this pediatric condition called infantile myofibromatosis, where these kids get these soft tissue tumors either in one place or multiple places of their body, and they take this drug called Gleevec or imatinib, and they can get regressions of these tumors that are caused by the same gene mutation. And so my suspicion is that patients who may have unresectable unicentric Castleman disease who have this mutation may in fact be susceptible to these therapies, imatinib, crenolinib, and sunitinib, I would say, were probably the ones that work the best. Okay, but that hasn't been done yet, but it would be, I think, something next that could be happening. And if this patient is really in a bad situation where they've tried all the tried and true things that I've had on my list here, then maybe it makes sense to them to try these things. They're well-tolerated medications. All right, and so these are the sort of things that I'm asking about the lab is to try to answer this question: what causes Castleman disease? Do these cells play a role? Since they're so good at talking to white blood cells, do they sometimes go bad? Is this why we've been missing it for so long? Because we keep looking for the cells that make up most of the cells that are there in the lymph node, when it's actually these rare controlling cells that have been what's wrong. Actually, a lot of times when clinicians or scientists try to investigate lymph nodes, they do it by the strategy of, it's like, let me get a little gruesome, Jack and the Beanstalk. They sort of grind up the lymph node mechanically, and then they get a single cell suspension of cells that they can then say what's what. Well, all these structural cells are part of the extracellular, maybe they're all part of this connective tissue. And then they get lost because they don't go into suspension that way. And so they never analyze them. You have to use a mixture of enzymes to get them into solution. And so that's why my suspicion is this could have been missed for a while. We didn't previously have good tools for studying these cells. So that's one of my hopes, that we have a brighter future where we have better ways of diagnosing this disease. So it's not just you got your lymph node to a fancy place and where there's a Castleman disease experienced pathologist happens to be there, that we can have better ways that are universal for diagnosing these, and some new treatments for the things that, for patients who haven't been having a lot of success with what's on my list. Cool. And I thank you all for your work in participating in all of our research, whether that is the clinical trials and sharing your medical information with us, or providing even actual, your blood or your lymph node tissue, because that's been the engine that makes all of this possible, because we really want to change things. And this is, I think, hopefully, I find it to be an exciting time where we have things to do and a new space in which to do it. So thank you guys for paying attention to me, and I'm happy to answer any questions. Even if we're out of time, I'm happy to just stick around and talk about anything with you guys. I think we are out of the formal time, right?
Yeah, we're.
So, okay. So I'll stick around. So
And you're gonna be at the physician Q&A panel.
yes, exactly.
Just ask questions there.
Yeah, awesome. Great. All right. And thank you to everyone in the World Wide Web.